response be? So, and I'm picking these things out because these are the things we're going to review throughout the year. Could be altered mental status, hypotension, that looks scary, respiratory distress, arrhythmia, and there's many other things, but these are some broad buckets of the things that you might see and some of the things we're going to review throughout the year. So where can it happen? It can happen on the acute care wards, subspecialty services. You can be on palliative care consults and you walk in and someone that was not cut for care is having trouble breathing and you got to activate a rapid response. Definitely can happen on night float. I know a lot of you, are the sole intern on night floats. So you might be responsible for activating a rapid response. Could happen in clinic. You walk in and your patient is not as well as they claim to be, and you now need to activate additional resources. And gosh, you could just be coming in to go to a lecture and you see a patient down in the hallway and you might have to call for additional resources. It's called something slightly different, but same kind of way that you'll act, activating that rapid response. So just remember not to scare you, but it really could happen anywhere. So we want to give you those tools to be prepared. So what do? You're thinking, I'm a day 2 intern. I don't know everything yet. Some of you may have had more experience, some of you have less. So what do? Well, just keep in mind, first of all, you are absolutely never alone. Even when you're that sole intern on overnight, there's an attending there and they're there to communicate with you and help you. So I just want you to know, no matter what happens, you are not alone. You are not working in a silo. So what is your job? So the leader's job isn't to know everything. You could walk into that room knowing absolutely no medicine, but if you know how to facilitate, and you'll hear me say this again and again, you know how to facilitate, you should be able to get the resources you need for your patient, the people that know the medical knowledge that you might not know yet, and be able to help that patient significantly. So really, what do you need to successfully lead a rapid response? Good teamwork, good resource utilization. So we're going to talk about that today. And just to not scare you all, you're probably not going to be leading rapid responses for the first year as an intern. However, you may be the first to walk in and have to kind of facilitate these things for the first 5 minutes till other help arrives. So we're going to prepare you for what do you do in that circumstance. So our goals want you to develop a plan for the first 5 minutes of a rapid response. Today, we're going to review the steps to facilitate that rapid response. We're going to talk about some of the resources that you need to activate, and then some resources that are available to you to help you guide you through a rapid response. And then we'll talk about best practices. What we're not going to do today is get into too many of the specifics about specific pathologies, but we will be doing that throughout the year. So this is just kind of the framework to use. We'll talk a little bit about some of the rescue maneuvers you can perform, but know that how to approach respiratory distress, arrhythmia, shock, that's coming as you go through the year. So I'm going to pull up a video real quick. Realizing I didn't load this, sorry about that. You'll see some familiar faces in here. But we're
Meet your next pillow. Why do we make our pillow
watch a video of a rapid response?
I'll tell you.
I'd like to get your...
The problem with...
Do we have sound, Emily? Are you hearing it beeping? No.
Not yet.
Oh, let me reshare my screen. That might be the issue. Sound? No. Right.
Hi.
Well, let me think how to best do this. Let me try one more thing. Can I try sending you the video link?
Oh, we have someone who said they might have been able to hear it, so maybe try again. It could,
Okay.
If it's on my end, then feel free to play.
Let's see.
Hi, my name is Vince. I'm the senior resident.
Are we hearing sound? Oh, we are. Okay, perfect. Okay. Thanks for your patience. Good night.
Hi, my name is Vince. I'm the senior resident. I'll be leading this rapid response. This is Kyle, my colleague, the intern who will be working with me. Can you remind me of your names?
I'm David. I'm the bedside nurse.
I'm Alex from the stat nurse.
Thanks, Alex and David. David, do you mind telling me what's going on here?
Yeah, this is Mr. N. I came in to do vital check and had all this blood all over him, and he says he feels sick. And so I called a rapid and then Alex came.
All right, sounds good. Can we go ahead and get a full set of vitals?
Full set of vitals. Alex, there's a full set.
Mr. N, can you tell me what's going on, what you're experiencing?
Yeah, I'm feeling really weak and lightheaded. I was just watching TV and then I vomited blood.
Okay,
Sorry, sir.
I'm very concerned that this patient is having an upper GI bleed given this presentation. I'm also looking at him and seeing only one point of vascular access. Alex, would you mind getting establishing 2 large bore IVs for us?
Yeah, sure. I'll put in a second IV.
Thanks. Kyle, would you mind looking up this patient in the electronic medical record? Get a past medical history, most recent H&H, coags, and code status, please?
I'll pull up the chart right now.
All right.
Dr. R, the blood pressure is 89/40 and the heart rate's 126. And SATI 94. Is it okay if I put him on some oxygen?
Yes, please.
All right. This is before I got promoted from being a nurse to a attending. All right, let me re-share my screen here. Y'all can see the PowerPoint again? We good? Okay, sounds good. All right, so I wanted to start that out with just giving you an example of what I would call, because we directed this, a successful rapid response. And we'll come back to later, we're gonna watch it again, we're gonna talk about what are the things that actually make it successful. Probably what you saw is a room that was very organized, was very calm, and was getting things done in a very organized fashion. So when you're leading a rapid response, the framework we're gonna use, and we'll go through each of these things, is first, your primary survey, address immediate stability, and then get and use help. And we'll go through each of those. So primary survey, first thing you do when you want to walk in the room, get your vitals. So, you could walk in, there could be vitals up on the screen. Those might be from 2 hours ago. So get a fresh set of vitals, first thing you do when you walk in the room. And then you want to assess immediate stability. So that's your airway, breathing, circulation. And I almost like to think of this as another vital, but get your code status, because that can tell you how aggressive you can be with this patient, whether that's, hey, they're full code, so I could be more aggressive, or hey, they're DNR, DNI, so I don't even want to get to a place where I would need to intubate them. So I actually need to be more aggressive off the bat, knowing that I can't really rescue them if they get much worse. So always, think of your vitals and then your code status is almost one of those vitals. So we're going to talk about addressing immediate stability. So we assess our immediate stability, we look at airway, breathing, circulation, we figure out how sick is this patient, and then we're going to address each of those things. So addressing immediate stability, airway. So you have a patient that may or may not be protecting their airway. What are some of the things you can do to stabilize that? So you can reposition them, you can suction, think about reversible causes. Is there something in the airway that you could potentially remove? Can you give something to open up the airway? Is this actually someone you need to intubate? Is this someone you need to call intubation on and get additional resources? Do you need respiratory therapy, ICU, anesthesia? Is this actually a surgical airway and you need to call people sooner rather than later? So think early on, what are some of the things I can do to temporize? And, this isn't really even complex medicine. This is just basic. What are some of the things I can do to try and keep this person's airway open and then figure out what the next steps would be? And then breathing. So you're assessing the patient's breathing, thinking, do they need more oxygen? Maybe they need actually positive pressure. Again, are there reversible causes? Something that I can easily fix to stabilize this patient. And again, is this a code intubation? Do I need to get anesthesia here sooner rather than later? Do we need respiratory therapy, ICU, anesthesia? And for each of these resources, I really want you to think of it as, if it's on the tip of your tongue and you think you might need it, go ahead and call them, because it takes time for people to get there. And I'd rather you have their resources there and send them away. And gosh, maybe you're a little embarrassed than not have them there when you need them. So I always think if you're thinking about it, you might want to activate them sooner rather than later. So quick question for the group, and I'll have you just type this into the chat for the sake of time, but you're called to see a patient with new hypoxemia to 81 on room air. You ask the nurse to start O2 and you're on your way. How much oxygen do you want? A, 2 liters nasal cannula, B, 6 liters nasal cannula, C, non-rebreather, or D, start the nasal cannula and up titrate till they're satting greater than 88%. So go ahead and type into that, or you can unmute if you're in a group and let me know what you're thinking.
Is anybody else going to answer? We like C.
Oh, well, that wasn't supposed to happen. Okay. I thought I fixed that thing. That happened during transition residency too. So I agree with C. So why am I thinking C? So if you had a patient, we say satting above 88 or 90, why do we need to jump straight to a non-rebreather? Well, non-rebreathers are a really good rescue measure. So I'm going to go through the different types of oxygen. This is something you probably have a fair amount of familiarity with, but I just want to talk through it a little bit more. A non-rebreather is a rescue measure. So you can get that patient's oxygen up really high while you're on your way. You don't know what's going on, especially if oxygen is below like 80% on a pulse ox. It could be anything. It's not good at picking up on the actual pulse ox below 80. So put them on the non-rebreather, get them satting okay, and then you can always down titrate later. I'd rather you do that than start them on 2 liters, that's not quite enough, or 4 liters, and it's not quite enough. So it's a really good rescue measure. But let's just quickly review what are some of the types of supplemental oxygen that you can use as a rescue in these situations. So we have nasal cannula. So that can go up to about 6 liters. Obviously, you can turn it up to 15, but after 6, it doesn't really do much. Just keep that in mind. And 6 liters gives you about 44% of oxygen. That's because of all the entrained room air that's coming in with the nasal cannula. Next, we have an oximizer. And that, you've probably seen these before. It's either like the little mustache well or a well that kind of sits around the patient's chest, and that concentrates the oxygen. So you can get a higher percentage of oxygen. Usually you go up to 15 liters, but even that, you're still getting a fair amount of entrained room air. So it's not going to be 100% oxygen. Next option is non-rebreather. And this is not a permanent way to give a patient oxygen, but it's an excellent rescue measure. So non-rebreather goes, you have to turn it up to 15% all the way. And the whole idea is that you can't rebreathe. So everything's going through without my asking it to. You can't rebreathe. So theoretically, what happens is you breathe in, and when you breathe out, the oxygen, it's a one-way valve. The oxygen goes out, or the carbon dioxide goes out, and you can't breathe it back in. So you really are almost getting 100% oxygen there. With that said, you have to have the oxygen all the way up, or you're kind of suffocating your patient. It doesn't really work that way in practice because there is some room air that can get in, but keep that in mind. You have to have it turned all the way up to 15 liters if you're going to use it. But it's a great rescue measure. Then we have high flow nasal cannula. So that can give you a much higher flow of oxygen. Gives you a tiny little positive pressure, but that's not really what it's for. So keep that in mind. And this is great for hypoxemia. And then last, we have BiPAP, CPAP, that gives you positive pressure with a higher percentage of O2. And I'm going to talk in a second about the indications for it. And outside those indications, you really shouldn't be using it. Keep in mind, this is something you want to use with caution with any patients with altered mental status, because you have an altered patient with something strapped on their face, blowing air into their mouth. You can blow saliva into their mouth, vomit, anything, and they wouldn't be able to pull it off. So it's not a hard contraindication, but generally when someone's altered, you probably want to avoid doing BiPAP. So indications for BiPAP, because I feel like this is a really important thing, and I see a lot of people get through residency without really fully grasping this. Hypercapnia, so the positive pressure helps wash out that CO2. Volume overload, positive pressure helps fluid reabsorb into the vasculature, and then neuromuscular dysfunction, some with ALS or MS, that their diaphragm isn't working correctly. Other than that, you really shouldn't be using BiPAP. People do a lot better on high flow, so keep that in mind. Any other indications? Probably reach for the high flow. You need the oxygenation rather than the positive pressure. And there's risk to BiPAP, right? You have something strapped on someone's face, like I said, blowing air in, and they might not be able to pull it off. So keep that in mind. All right, so moving on, address immediate stability circulation, so your C. So think, do you have IV access for this patient? Maybe get 2 large bore IVs if you can in most cases. Do we need to give volume? IV fluids, blood. This will be specific to the situation. Replace what's lost if you can. Do we need pressors? Do we need a cardiovert? Or are there some kind of, again, reversible causes that we can fix to fix the circulation? And then do you need to activate other resources like MICU, CCU, surgery? So you've thought through you've assessed your ABCs, you've addressed your ABCs, stabilized that patient. Now you're going to think, what is the framework I want to use to actually lead this rapid response? So first thing you do when you walk in the room, identify yourself. Like someone said, what is your role? My name is Alex and I am the rapid response leader. Stand at that foot of the bed. You can see Dr. Reichel there. He's at the foot of the bed. Why? Because you're at the foot of the bed. You can see the patient. You can see everyone in the room. You can see the monitor that's going to give you the vitals. It gives you a great view of the room. And it's kind of the universal signal that you're the leader. Every intern that does rapid response simulations with us wants to stand where I'm standing there over in the corner by the bedside. That's where anesthesia stands. Do we have anesthesia prelims in this room? Emily?
We have one here at the VA currently.
Okay, we have one. So everyone except for that one intern, just don't stand there. For that one intern that's anesthesia, keep in mind, you can stand there when you're acting as anesthesia, but there may be times where you actually become the rapid response leader. Like you're in a case and the patient starts to crash and you become like the code leader or something. So you're actually going to position yourself at that foot of the bed. And then when you go back to being anesthesia, you can walk right over the spot. But it really is the universal signal to everyone in the room, who you are and what your role is. You want to identify team members, assign roles, see what roles you need. Do you have everyone in the room that you need? Do you actually need to activate more people? And as we go through the simulations this year, we're going to talk about what are some of those roles that you can assign. Get the story. So this is very brief. You don't have time to, figure out what happened 5 years ago when this patient saw rheumatology. We want events leading up to the rapid response, quick past medical history just to be relevant, and then medications that would be relevant. And then the big one, call for additional resources. So you're really doing these things in order. Identify yourself, stand at the foot of the bed, identify team members, assign roles, get the history, call for resources. So who's your number one resource? Stat nurse. Keep in mind, at all the different hospitals, we have nurses that go all day from rapid response to rapid response to rapid response. So they know the pathology, they know who to call. They can really, really be helpful. They can help assess your patient. They can help with the workup and treatment. They can help figure out what additional resources you need to activate. They can also help with triage, whether it's figuring out what level of care the patient needs or just kind of helping with the transition if you're getting any pushback. And they really turn the room into an ICU temporarily. So during rapid response with your stat nurse there, you can do anything or pretty much anything requiring, maybe other than like renal replacement therapy or something in a room that doesn't have the hookups for that, but you can do anything that you would need to do in ICU. So use them for that if needed. I'm not going to go through all these, but I know you all have access to this PowerPoint. I wanted you to just be aware of the different codes that we have at the different hospitals. They're slightly different for each hospital, but we have different codes like behavioral emergencies, code sepsis, code stroke. But the main ones I want you to know about is rapid response, code intubation, and code blue, and what separates them. So who should you call? It's actually pretty simple. If there's breathing and a pulse, that's rapid response. If there's no breathing and a pulse, that's code intubation. Or if you're worried that there will be no breathing, impending no breathing, and then no pulse, code blue. With that said, I would always rather you call the one to the right there if you're worried. So if you're in a rapid response and you think it's a rapid response, but gosh, this person's breathing's not great, call the code intubation. It will get you all the same resources. You'll get your rapid response nurse, your stat nurse, your respiratory therapist, and you'll also get anesthesia. Each team comes with additional people. If you're worried this person's about to lose a pulse, just call the code blue. The code team can always leave you with the stat nurse and the anesthesiologist. So always err on the side of being more aggressive when you're calling these codes. And then, communicating with your team. You probably saw in that video, things were pretty calm. There was really good closed loop communication. So very early on, identify your team members. If possible, try and get names and even maybe write them down. or at least get roles. So you can call people out specifically and make sure that they understand you're talking to them. Use that really good closed loop communication, and once you start doing it, you'll see other people in the room start doing it back to you. And even if you're a member on the team and not the leader, make sure you really try and initiate that closed loop communication. Summarize the case often. People are going to be coming and going into the room. And if you can take a moment, fill the silence with summary. If there's an awkward silence, just say, all right, everyone, I just want to refresh. So we have a 34-year-old male came in with shortness of breath, is now, in respiratory distress. This is what we've done for them. Be really beneficial to your team. And then once you summarize, ask your team for input. There's going to be people there that are seeing things you might not be seeing because you're focused on one thing or another. Make sure that you get input from the team so that you can more comprehensively treat this patient. So putting it all together one more time, and then we're going to watch the video again and kind of point these out. So you walk into the room, identify yourself, get vitals, stand at the foot of the bed, assign roles, assess immediate stability, your ABCs, address immediate stability, ABCs, get the story, and then get help. So we're going to watch that video one more time. And I'm going to kind of point these things out, and you'll see how it flows very nicely, but they're following a very specific algorithm.
Hi, my name is Vince. I'm the senior resident. I'll be leading this rapid response.
Introduce himself, stood at the foot of the bed. You all can hear that, right? Okay.
This is Kyle, my colleague, the intern who will be working with me. Can you remind me of your names?
I'm David, I'm the bedside nurse.
I'm Alex from the stat nurse.
Thanks, Alex and David. David, do you
There he went, just identifying other team members.
mind telling me what's going on here?
Yeah, this is Mr. N. I came in to just do vital check and had all this blood all over him, and he says he feels sick. And so I called a rapid, and then Alex came.
He's getting his quick history kind of within this.
All right, sounds good. Can we go ahead and get a full set of vitals?
Full
Getting your vitals.
set of vitals. Alex, there's a pulse ox.
Mr. N, can you tell me what's going on, what you're experiencing?
Yeah, I'm feeling really weak and lightheaded. I was just watching TV and then I vomited blood.
Okay,
Sorry, sir.
I'm very concerned that this patient is having an upper GI bleed given this presentation. I'm also looking at him and seeing only 1 point of vascular access.
There he is. He's assessing immediate stability. What are we doing with our circulation? Addressing it, thinking about that.
So do you mind establishing 2 large bore IVs for us?
Yeah, sure. I'll put in a second IV.
Thanks. Kyle, would you mind looking up this patient in the electronic medical record? Get a past medical history, most recent H&H, coags, and code status, please?
I'll pull up the chart right now.
All right.
Dr. R, the blood pressure is 89 on 40 and the heart rate's 126. And satine 94. Is it okay if I put him on some oxygen?
Yes, please.
And you can see even with that, he's getting input from the team, kind of summarizing what he's thinking. He's assigning roles, even like to the intern. Could you please go look these things up? Because I have other tasks I have to take care of right now, but these things are important. So I think that's why, at the end of the day, you see this fairly calm, organized code is that algorithm that's being followed really to a T. Okay. All right, so just real quickly, once you've done that, that's really the first 5 minutes. It's make sure the patient's stable, get who you need in the room. Then you can start thinking about the other diagnostics. What's actually the nitty gritty of what's going on here? And that's kind of what we'll touch on when we do these sims throughout the year. But what are some other diagnostics that you need to get? Do you need labs, EKG, chest x-ray, KUB, other imaging? And these are things you probably will have time. Someone will have showed up at that point. You'll have time to talk about them with other people, talk to your senior. You could look on UpToDate. Now that your patient's stable, you've bought yourself some time. But the biggest call out I wanted to make for you all is imaging is important, but never move an unstable patient because you might wind up coding them in the elevator, and you should never code a patient in the elevator. That's my other key point from today. Do not code patients in the elevator. Always make sure they're stable before any kind of imaging. So you want to make sure you've completed that first half of the algorithm before you start moving on to imaging. Other than, KUB or portable chest x-ray is fine, but don't move them until you know that they're stable. You can always stabilize someone where they are, even if they're on an acute care floor. And then also just keeping in mind, there's other things we could do. You all are going to be really well versed in POCUS by the time you get out of this program. We do a really good job training you. But keep in mind, if you're going to do something in the bedside, do you actually have the skill set to interpret it and use that data to make a decision? And it's fine to do it, but keeping in mind there might be other things that you want to have take priority. So, if you have a patient with that you think has pericardial tamponade, but you don't really feel confident in making that call and POCUS, maybe your efforts aren't best spent doing the POCUS at that moment. It's better spent calling the person to come do it or giving them fluids or something else. So just keep in mind, if you're going to take time to do some kind of diagnostic maneuver, that you feel confident using the data. I personally, I kind of know POCUS, but not well enough to use it. So that's not something I usually do in an acute decompensation. So, let's say you stabilize the patient or you get them to the ICU, you're ready to leave the room. Just keep in mind, it's really important at that point in time. I've very frequently seen interns or residents finish rapid response and just kind of wander out of the room, and everyone's left in there thinking, oh my gosh, what do we do with this patient? The nurse is going to start hemorrhaging you. Summarize the case again. Take that moment and say, okay, we think this patient's stable. We've done this. Next steps are this. These are the things I need to be called for. So do that formal handoff and give the plan to the bedside nurse. And then the other thing is stay nearby. Usually if I have rapid response, I'm working for the next half an hour at the nurse's station. I'll peek in on that patient. This is not the time to go down to the cafeteria. As much as possible, try and stay nearby or of some way that you're easily accessible. And then we'll talk about this a little more, but would really put in a plug for document. It's really helpful to have a record of what happened in the documentation, and this can be a really simple documentation that'll really serve the patient. And then one other thing I just wanted to plug, I think there's this bias that we all come into residency with, I like to call it the well bias. I made that up. But it's a bias that happens when you're in medical school and a patient's sick and you go and tell your senior or your attending, and they go and see the patient and they think the patient looks fine, and now you're embarrassed. And we all get this bias that we are scared to overreact. We'd almost rather underreact because overreacting is embarrassing. And maybe everyone doesn't have this, but I've seen it time and time again. And I think it's something you really want to break away from, especially as an intern. So what are the risks of underreacting? So you could delay help. You might not go and see the patient at bedside. The nurse calls you about something, you say, I'm not really worried about it. We got other stuff to do. I'm not going to go see them, when you should have. You might miss sick patients. You might cause harm in the patient. And even at the very least, you might make the patient feel dismissed. So let's say on the flip side, you overreact. Well, you'll feel a little embarrassed. Okay. If you call people you didn't need to call, you just apologize, thank them for coming, and they leave. That's what they're there for. Now, you might get, it shouldn't happen here because honestly, we have a pretty good culture at UW, but let's say you call your attending in the middle of the night because you're scared about a patient and they go, they're fine. Why did you call me and wake me up? Well, honestly, that's that attending's problem, not yours. I would rather be called 10 times and one time the patient's sick rather than you not call me that one time. So break the culture that we have of people, being upset when they're called unnecessarily. If someone gives you a hard time for activating, them for some reason and the patient's not actually sick, that is a problem with them, not with you. You did the right thing. Just keep that in mind. I know it feels yucky, but you are doing the right thing by that patient, and that patient is your priority. Also, you're no longer graded or ranked or anything like that in residency. So just do what's right by your patient and do what's right by you. And then, at the very least, you call someone unnecessarily, you talk about it with your resident about why you should or shouldn't have called, you learn something. So I'd really challenge you, if you're tempted to say, no, the patient's fine, really challenge that wellness bias, that well bias, and make sure that you take care of your patients. So that's the framework. That's the kind of thing I want you to come away from today. We're going to practice that as we go through the year, but I just want to quickly touch on some of the resources that we have available to you here at UW. So the first one is the Occam Rapid Response Toolkit. Hopefully some of you have already used Occam. If not, I'm not going to go through exactly how to download it, but I have slides on that here so you can look back at the slides and make sure that you can get access to it. This is a really good resource. Some of you probably more commonly use it for antibiotics, but we have a rapid response toolkit in there. You can use it on your phone or you can look it up on a computer. And it's meant to be used to just provide quick cues for medical management, drugs, diagnosis, things like that at your fingertips on your phone. So all the way on the left-hand side here, that's what the screen of the page looks like. We have altered mental status, shock, respiratory distress, arrhythmia. And if you click on one of those categories, it gives you kind of either an undifferentiated, for example, shock management or different types of shock. And if you click on those, it gives you like really just quick medical cues for how to manage them. So like for shock, assess airway, breathing, circulation, give O2, get your IV access, call rapid response. And then probably the most useful part as you get further along in your training is the drugs. So for each of these categories, it has high yield drugs for the different diagnoses or just kind of broadly for that category and their doses. So this can save you some time with those quick things you need to know, like a seizure, lorazepam, what's the dose? What's the second line dose? What do we do for anaphylaxis? So I would really encourage you to have this available. I think it would be really useful. And then even as you get further along in your training, we also have this section, emergency response teams. And for each of the hospitals, it has the phone numbers to call to activate different teams like RT, rapid response, and you can actually dial through the app. So I'd encourage you to use that as well. It also, the cardiac arrest section has your code cards in it. So another quick way to get those. This next page just has how to download it, but I'll let you look through that on your own time. And then I want to make a plug for documentation. I think it's something that doesn't happen a lot, and I appreciate you all write a lot of notes, and you're probably really sick of writing notes. But documentation for a rapid response is really important. It promotes communication among team members. You may have been there. The consultant that's taking care of this patient that's really critical to that care may have not seen that or heard exactly what happened. The nurses, a new nurse comes on, they may have just gotten kind of whispered down the lane of what happened. It's really important to have that documentation. Helps you explain why you did what you did. It's really important for sign out too. So let's say you're a night intern, something happens and you give excellent verbal sign out, but 2 days later, nobody remembers that excellent verbal sign out, and it's kind of confusing what actually happened with the patient. So having a quick note would be really valuable down the line. And then just from a medical legal standpoint, these are high risk situations where you're making really high stakes decisions, and being able to explain that in writing can be really valuable. And to make things easier for you, we have a template. So if you type in significant event to the note template, to like the note type, this template pops up. And these notes are not intended to be exhaustive in any way. When I write them, the brief summary of the events, usually like 2 to 3 sentences. My pertinent vitals, I'll just say hypotensive, 90/60, that's it. Exam, I might just say, abdomen hard, that's it. Just the really pertinent things, get them down. Same with the assessment plan. This is your this is what I thought, this is what I did. You don't have to go into all the specifics or all the other problems. And for early in your training, we've included this part that if you type in .rrap, and that shows up in the note, it'll give you a selection of common problems that you might encounter for a patient. And if you click on them, I've kind of clicked on all of them here, you can see that it auto-populates a plan. And this is meant to be edited. There may be things you do or don't do or add in, but it can be helpful. Like, for example, if you have acute coronary syndrome and you forgot to get that INRPT, hopefully this will be a reminder for that. Alter mental status, what was the glucose? Things that we commonly forget that I think having in that note auto-populated for you might be helpful. So I'd encourage you to use it if you find it helpful. And this is available at Montlake and Harborview, the VA. Gosh, I don't even want to talk about CPRS. It's a whole other ball game. So then I just see something in the chat. Oh, are you not seeing my screen?
That was, it fixed a long time ago. You're
Okay.
good. Thank you. Sorry about that.
No problem. Good. So I'll just quickly describe to you what you're going to be doing throughout the year with me and Dr. Reichel. Throughout the year, you're going to have 5 sessions. I'll talk about them in a second. But today we kind of talked about the non-technical sides of rapid response, right? Leadership, communication, teamwork. Hopefully you get a little bit of confidence out of going to this lecture. And resource utilization. And then throughout the year, we're going to focus a little bit more on those things. We're going to practice them, and then also medical knowledge for certain things, diagnostic skills, equipment, things like that. So we'll kind of build on this. So you have 5 fun sessions, and they really are. People have really enjoyed them in the past. They're really fun. They're at each site, VA, Harborview, and Montlake, and they will be 5 times a year and run kind of around the same time at each site. So whatever site you're at, it will happen there. So just keep an eye out, make sure you attend the site that you're at. And you can do this whether you're on inpatient, whether you're on subspecialty, or even outpatient. Just go ahead and come to whatever site's more convenient for you. And the topics we're going to cover is altered mental status, hypotension, respiratory distress, and arrhythmia. And then we're going to have a post return of spontaneous circulation sim kind of at the end to wrap things up and start talking about what's it like to be a code leader. And then associated with these, there's 4 video modules for the first 4 topics. We encourage you to watch them before you go to the sessions. It's the one that I showed you today is one of the start of one of those. And they can be really helpful just to get a framework, and then you get to actually practice it in person. So we have you show up, we break you into groups. We have you run a simulation with a patient, and I know, simulation, but we've really seen from the interns and for people that have participated that it feels really real, and it's just a great opportunity to practice and, get to hang out with your colleagues, and someone's holding your pager. These are required, and you get to leave work. So that's the benefit of them. So usually we do a simulation, we do a chalk talk on the topic of the day, and then we do a second simulation. So you gotta get to practice the framework of how to approach that specific emergency. Here's an example of some of the chalk talks we do. And it's that same, the whole goal with these sessions is provide you frameworks that you can use so that you can kind of fall back on that when things are stressful and the room's chaotic and things like that. So you don't have to be thinking, oh gosh, how do I make these really complex medical decisions? You have that framework that you can rely on. And that's it. I'm really excited to see you all throughout the year. Remember, these are required, but we're excited to see you there, and I think you'll have a really fun time. We have a QR code up here for evaluations, but I'd love to get any questions from anyone.
While people are thinking of questions, if you guys can do the QR code scanning and evaluations, that's super helpful. We use your feedback to guide us for next year's sessions. And so it's super important. I'm seeing a question from HMC. Can we get access to these PowerPoints? The good news is I will send out the PowerPoints after the session to the correct listserv, and I will also post a recording. So for anyone who misses any sessions for days off or things like that, we'll have them posted as well.
This POCUS. Yes, Emily, maybe you'll be able to answer this better than me. Where can we practice POCUS? I believe they have some training.
Yeah, so I think you guys have sort of just-in-time POCUS training kind of throughout the year. I also know you have an option for a POCUS elective. So if that ends up being something you want even more dedicated time to do, there are like POCUS electives kind of for R2, R3 years. But there should be POCUS trainings like as just-in-time trainings during the year. I guess the question about practicing POCUS, I know for the VA, we have an ultrasound that anyone is welcome to borrow and try to use if you want to practice. I think there's not necessarily like an open sim lab per se.
Also, you can always grab one. I know I'm on like, at least you could always just like borrow it off the floor and go to your team room and play around with it. Sometimes I'll do that with the teams.
Well, thanks you guys so much for coming. Thank you, Dr. Collis, for giving us such a great intro to rapid responses that you're going to build on throughout the year. We're getting some claps from our various sites. So thank you so much. I will send you guys a email when we get back from July 4th, kind of with the updates for our next session. But just anticipate over the summer, we'll be meeting every Thursday to get through really the most high yield kind of big things of intern year. So thanks again, and have a good rest of your week.